So today, oh, there's Charlie. Today we are looking at day 10. This is going to be the shoulder, elbow, and wrist joints. We'll talk a little bit. Honestly, we're going to spend most of our time on the shoulder because we've actually got two separate sort of sections to talk about there. We've got your shoulder joint and your shoulder girdle. And they are separate of each other, but they are also interdependent on one another. So, you know, they're separate things, but they're very important to kind of understand how they work as a unit. And then we'll talk a little bit about the elbow. We'll talk about like what muscles do elbow flexion and elbow extension, things like that. A little bit of pronation, supination. We'll look at those movements. But the wrist, we're not going to spend a ton of time on the wrist. I'll probably move through that pretty quickly, just because it's not really in your textbooks. You're never tested on it. And honestly, like if there are wrist problems that your client's having, like generally that's something they're going to need to see a specialist for anyways, because the wrist is kind of a unique joint. So anyway, these are kind of the structures we're looking at, right? We've got here, you can see your collarbone interacting with your scapula. That is going to be your shoulder girdle. Similar to how your pelvis was the girdle that holds your legs on. Well, this is the girdle that holds your arms on. Then we've actually got the shoulder joint here as well, where that ball and socket joint. So this is a similar arrangement you guys might notice from yesterday, right? We had the hip girdle, and then we had the hip joint, which is where the femur is inserting onto the pelvis. Well, the same thing's happening here. This is where the humerus, instead of the femur, is inserting onto your scapula. That's your shoulder joint, but the shoulder girdle that holds it on is the scapula interacting with the collarbone. So that's one of the distinctions we'll be looking at today. Then moving down to your elbow, you can see here that primarily hinge, primarily a hinge joint. This actually wraps all the way around here. And then you can see, there is like a rotational movement that happens here, and that can allow pronation and supination to occur. So your bones can kind of twist one over the other. And then in your wrist, you can see all these individual little carpals here. Your metacarpals, which make up the palm of your hand, and then your phalanges, similar to our arrangement in the ankle, right? We had our tarsals, our metatarsals, and our phalanges. Well, now we have carpals, metacarpals, and phalanges. So pretty similar arrangement. Like I said, that's kind of the classic mammal structure, like the one bone, two bone, lots of bones structure that we see, which sounds like a really like lazy Dr. Seuss rhyme. What the Dr. Seuss and the one bone, two bones, I don't know, lots of bones, digits. So let's take a look here and define each of these again. So the shoulder girdle is going to be made up of your clavicle, that's your collarbone, and your scapula, which is your actual shoulder blade. It's called scapula, by the way, because it looks like the head of a shovel, and that's what shovel means in Latin. It means that's what scapula means in Latin. It means shovel. So it kind of looks like the head of a spade. So they move as a unit. That's the thing that's obviously very important to remember here. They move as like one movement. If one of these bones moves, it is going to affect the other one. And here's a kind of a fun, interesting little fact here. Your clavicle here, where it is going all the way across and inserts onto your sternum right here, that's the only bony connection you've got for your entire arm onto your axial skeleton, which is crazy because we can hang from our arms, and manage to not, dislocate this joint. That's actually a very, very, very small joint there, which I always think is kind of fun. So that's your shoulder girdle, the clavicle, and the scapula. Then you've got your shoulder joint, and the shoulder joint is your humerus interacting with your scapula. So this is that ball and socket joint that we're thinking of. And so this is the most widely, wide range of motion that you have in any joint in your body. Obviously, ball and socket joints are already very mobile, but this one in particular is there's a large joint cavity there, which is great because that means that we have lots of range of motion, but it's not so great when you consider that dislocations and subluxations are most common in this joint. You know, you can dislocate any joint in your body, but when's the last time you guys heard about somebody dislocating something that wasn't their shoulder? You know, and it can happen in the hip too, which is horrifying. But we definitely see instability as like an issue here in the scapula, which is one of the reasons why it's so important for us to train our clients for stabilization. We also see a lot of rotator cuff impingements happening in here, which we'll see in just a second, where there's actually soft tissue that comes up over the top of the scapula and then, over the top of the humerus there, and then embeds itself into the scapula. And it looks like this. It's literally where these little tissues start getting pinched in between the hard tissues, right? This like little soft stuff is supposed to work its way through here and have plenty of room to move. But if it doesn't have very much room to move, it's going to get pinched in between those hard bones, and so you know that's why they call it impingement. It sounds like impingement, right? Then we're going to see your elbow. Your elbow is the articulation between your humerus and your radio-ulnar joint. So where your radius, which is this little rotational bone right here, and your ulna, which is your actual, like, you can feel your elbow at the bottom there, right? So what's cool is like your elbow joint is acting as the hinge joint, right? But your radio-ulnar joint is what's allowing pronation and supination to happen, where those bones twist over one another. So that's kind of cool, right? This is kind of similar to our arrangement in the tibia and the fibula, right? We can see like this little rotational bone off to the side. Again, mammals, one bone, two bones, right? And then lots of bones and digits. Here's the lots of bones, right? Here's all of our individual little carpals, these little tiny cuboid bones or square bones, right? The carpals of the wrist. This is like oftentimes when you hear somebody like fracturing their wrist, oftentimes it's, you know, something that happened down here. And then it would continue into their metacarpals, which would be the palm, and then their phalanges at the end there. So our most common injuries that we're going to see, at least in these areas, right? General shoulder pain, just kind of getting that out of the way, kind of similar to general low back pain, right? Is any and all pain in the glenohumeral joint inside of the in the scapula, right? So what that is, your glenohumeral joint, the reason it's called that is it's your humerus, like that's the humeral part, and then this little gap right here that you can see, this little like cavity, this little gap where that inserts, that's called your glenoid cavity or your glenoid fossa. And it's where this ball and socket joint is interacting, right? So because that's called the glenoid cavity, this is your gleno, and then this is your humerus, glenohumeral joint. So we definitely see a lot of pain in that, right? Actually, really quickly, in this call right now, do any of you guys get a shoulder clicking when you do like shoulder raises or overhead presses or anything like that? Anybody get a clicking?
Yeah, sometimes.
Yeah, a little bit, right? So that's obviously not supposed to happen. If it doesn't hurt you, it's not really causing too much problems. Like, you know, as long as like that clicking isn't also painful, you're fine to keep exercising. Like this isn't a situation where it's like, oh yeah, back off, right? But it is a situation that like you are on the sign, or on the sign, you're on the road to like more severe shoulder impingement, right? So there's a little bit of tightness in there, and what's happening is that clicking that you're feeling or hearing are just those little tendons and those little ligaments. They're just kind of rubbing over like hard bone, right? So it's kind of like, honestly, like imagine if you had like a, I don't know, something kind of textured like this, and you were running a rubber band over it, right? It would be like whack, 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 right? Not awesome. Luckily your body heals stuff, you know, it's like, you know, rubber band that actually just gets worn out over time. I'm saying that because I need to replace my resistance bands right now. But you can feel like it's different, right? It's there's a little bit of a rubbing sensation there. So if we, you know, restore that range of motion, that sensation goes away. So even Charlie, just like pinching your shoulder blades down and back before you do things like lateral raises could have a really positive, really big impact. So shoulder pain, it happens about 21% of the general population. That's about 1 in 5 people, which is, pretty substantial. It's included, part of this includes shoulder impingement syndrome, which we're going to look at down here, which is that pinching, right? That 40, most shoulder cases, like 40 to 65% of all cases are shoulder impingement. And impingement just happens when, you have a client who kind of sits in an unideal posture. Your body develops these improper length tension relationships, and then it, can't recruit the way it's supposed to. We'll also see traumatic dislocations happen as well. So dislocations are basically where this joint is going to move outside. I had a client dislocate themselves in the lobby once. It was awful. She got really excited and she was just like, I gotta show you this thing. And she was trying to run around the front desk to like come to the back. And she just slipped on the freaking concrete and just fell and just dislocated her shoulder. And we had to go to the ER and get it popped back into place. And it was like, ugh, that happened to Betty White. I don't normally reveal people's names, but not that Betty White. But yeah, she's great. She's doing really well now. Like we got her on a, we got her to fix her shoulder pretty well, but what a bummer. So anyway, shoulder injuries, dislocations can definitely happen. There's also general elbow pain, general pain in the elbow region. This is usually going to be associated with very repetitive tasks. So the big ones we're going to see, which we got down here, is either going to be lateral or medial, what we call epicondylitis, which really is just inflammation. Remember, it's an itis, it's an inflammation problem again, right? It's tennis elbow or golfer's elbow, which we'll see in just a second. So like I said, shoulder impingement, getting a little bit more specific about that, right, is the pinching of connective tissue in the shoulder joint, and that's going to cause inflammation and decrease range of motion. So often this is very associated with repetitive tasks. So you would think that maybe like let's say a painter, right? Like a painter who's, going like this, they're doing shoulder presses basically all day, right? You would think that person would be very, very good at overhead pressing, right? But what actually happens is you end up overdeveloping the muscles, right? You end up making them overactive. And remember, we talked about this, right? Like a lot of times, like it's okay to describe it to your clients like you got one muscle that's too strong, you got one muscle that's too weak, right? That's a simple explanation that gets you a long way very quickly. So it's kind of nice, it's a good quick rundown for your client. But the reality is overactive muscles are weaker than they are supposed to be. Underactive muscles are obviously weaker because they're in a big overstretched position. But your overactive muscles are also weakened. So when you start to develop overactivity, it's not that you are too good at something. It's that it's dysfunctional, right? It's in a shortened state. So we definitely see that in our shoulder impingement syndrome, right? And this creates inflammation. And that can sometimes even cause things in the shoulder like bursitis, where basically you rupture one of these little bursa sacs and then it has to repair and refill with fluid like way later down the line. And it takes a long time to fix, So that's shoulder impingement. And then we also see rotator cuff injuries. Now this, like I said, this is 75 to 80% of shoulder injuries or rotator cuff injuries, like strains, tears, ruptures, tendinopathies, which is kind of similar to impingement, etc. All the things that are actually rotating in the muscles that are rotating your humerus. So your rotator cuff, you can actually see if you look at these muscles here, look at how they kind of wrap around. If you imagine, actually, we can use my coffee mug here, right? So if you imagine like a muscle wrapping around from the back and I kind of grabbed it like this, that means that I can pull it around the back like this. So that's going to cause a rotational movement. And that's how your rotator cuff works. It's all these little tiny muscles. So if we look at the rotator cuff, it's these, that's a great picture. So it's these little tiny muscles that are actually like wrapping around and creating like these little rotary movements. And so here you can see there's like impingement, there's a rotator cuff tear, right? There's tendonitis where basically the tendon is just getting overused, right? All of these are going to be common symptoms that we see. And I was talking to, I guess, Andres, you'd be the only one on this call who knows what I'm talking about, but I was talking to Paul about this once. And he had just done like recertification or something. And he came back and we were talking about, you know, how his workshop was and stuff. And he was like, yeah, it's funny. They were talking about how they did so many autopsies, you know, because that's how they're studying these muscles, right? They're pulling them apart and stuff. And everyone's got a rotator cuff tear at some point. like there's nobody who gets out of this planet, you know, no one gets off this planet without first having some type of rotator cuff problem. Even if it's just like really minor, you know, they'll see the trauma from years later. So kind of funny if you think about it. I mean, this is obviously, you know, we live in a world with you know, we're sitting a lot, we're using computers, we're typing, we're driving, right? We're on our phones, all those things that are kind of tightening and pulling us forward, and not enough things that are kind of pulling us backwards. And then here's our dislocations, right? Which, oh God, there's a subplexion or a dislocation, right? Where basically this joint is no longer sitting in the cavity it's supposed to sit in. Generally, you can get this to roll back into place. A lot of times what you'll see them do is they'll take the shoulder across and then up, and then it kind of pops it back into place. Don't believe those movies. When you watch, what is it, Lethal Weapon 2, I think, where he's like in a straight jacket and he dislocates his shoulder and then he just pops it back into place by throwing it against a wall. That is not going to work. That is not how that's done. So if you ever experience a dislocation, to the hospital, please. So pretty common where this will happen. Sometimes surgery will be required. A lot. What you know, you got to remember that there's a lot of soft tissue that we're not really seeing in this picture here. Shoulder joint ligaments. When you look at your shoulder joint, it's covered in ligaments, you know, on all sides. And so, you know, if you are moving that bone away, you're probably tearing some of those ligaments. So you're definitely going to sprain that soft tissue within that shoulder joint. So sometimes that'll require surgery to repair, unless it's like a, you know, only a partial tear and stuff. Then other epidemiology we're going to see either lateral or medial epicondylitis. So lateral epicondylitis is inflammation of the lateral condyle. So this is pain along the outside of your elbow right here. This is tennis elbow. So when you're doing like consistent movements, right? And that's causing, usually it's associated with like really heavy gripping while you are also doing like rotational movement of the arm, like supination. So by doing like a heavy grip and supination, you're basically you end up rubbing this this tendon on this bone right here. This is really similar to IT band syndrome. I mean, honestly, they're extremely similar injuries, right? And basically, it's where this soft tissue is just rubbing on the outside bone there, and so it gets inflamed and becomes very, very painful. And then there's also medial epicondylitis, which is golfer's elbow, where we'll see it rub on this inside knob on your elbow right here. And so both those, can be very, 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 very painful. With tennis elbow, it's usually from backhanding. With golfer's elbow, it's usually from your follow through, I guess is what I would call it. I know nothing about golf. So that is going to be, your muscles in the wrist are going to be responsible for that. Your pronators and your supinators, they're going to get really tight and they're going to rub on those. And then there's carpal tunnel syndrome. I forgot this was up here. I didn't put it in the notes because we're not really doing wrist stuff. So carpal tunnel syndrome is a kind of a unique one, actually. And this is actually, I don't know, it's kind of similar to plantar fasciitis. Like plantar fasciitis is actually inflammation of your plantar fascia. Like the soft tissue is creating the pain because you're feeling that soft tissue's nerves like tighten up. Carpal tunnel syndrome is a little bit different. This is actually where your palmar fascia, which is the fascia in your hand here, gets so tight that it actually starts pushing on what's called your median nerve. And that's the nerve that runs down before branching into your hand to control your hand. So you end up like basically pinching a nerve. And that's what carpal tunnel syndrome is. Fun little fact about carpal tunnel syndrome. It is one of the symptoms of taking human growth hormone supplementation, which seems kind of weird, right? You would think like human growth hormone, there's obviously, taking HGH is very dangerous unless it's under like a doctor's supervision and needed in specific reasons. But bodybuilders and power lifters and athletes, they've sort of adopted it as a performance enhancing drug. I think if I'm not mistaken, A-Rod was taken like regular roids, but I think he was on HGH as well. If I'm, I don't want to spread any rumors, but I think that was the case. But that's what we see, like, that's what'll happen. And remember, human growth hormone, I always tell people it should be called human stuff growing hormone instead, because that's a more accurate description, because honestly, what it does is it just grows human stuff. It just makes stuff in the human body grow faster. So we think of that as like, yeah, it's making my muscles bigger. It's making everything bigger. Your bones are getting denser, and possibly you're getting bone spurs. Your liver could enlarge, your pancreas, right, which is going to give you diabetes. A lot of problems with taking this as a supplementation, but one of the weird ones, and one that I think is fascinating, is you will see carpal tunnel syndrome. And it's because you end up just growing all this like palmar fascia, and eventually like the nerve is trying to fit in the same little tiny cavity, but there's just not enough space anymore. So that's kind of a weird one. Speaking of that, by the way, this is just a fun fact about me. Speaking of like weird kind of hand diseases. So I got the freaking stenosis from my mom. My dad, I have inherited. So my dad's hands, his right one in particular, but his left one a little bit as well. If you were to look at his hand is actually stuck like this. His hand kind of looks like this at all times. And he can move his fingers and stuff for the most part. He can't really extend them, but he can move them. He can like pinch stuff and stuff. And then this one's kind of stuck a little bit as well, but it kind of looks like this, where the ring finger is more contracted. And that's actually what is happening. He is actually contracting this little ligament right here, all this like little fascia, right? And what that is, look at it, this is called palmar fibromatosis. This is a pretty rare disease. You're not going to see this very often, by the way. But it's sometimes called a Dupuytren's contracture. It's named after this French surgeon who worked on Napoleon, something Dupuytren. But it is where this band right here actually thickens up. And it's usually from working like really like construction jobs, where you work like really, really hard and you're beating up your hand. For some reason, your immune system decides to like create more and more and more connective tissue. It just decides to like create, it's like throw some more connective tissue on that. It keeps getting beat up. They don't really know why. It's sort of an autoimmune disease. But in really severe cases, you can see like it kind of gets stuck. And that's sort of what the hands start to look like. By the way, this is super easy to fix. You literally just go in for surgery and they just kind of scrape that stuff off, and you get your hands range of motion back. But my dad's too freaking chicken to do it. But anyway, the reason I bring it up, so I broke my hand in the gym, actually helping a guy who was falling a couple of years ago, and I had to be in a cast. And when I got out of it, I looked and I can actually start to see little dents in my palm. Now you probably can't see it on this little tiny camera, but there's little dents in my palm, and that is about as far as I can pull that back. But then you can really see that super thick band there, which is kind of interesting because I got full range of motion back here, So that's like a surgery that I'm going to need probably in my, mid 50s or something. But it's heavily associated with like construction jobs. My dad's a furniture mover, so you know he's beating up his hands all the time. Anyway, kind of a fun one. I've only seen this twice in my dad. Actually, you know, my uncle had it as well, his brother. And I've only seen this once in my career. I had a doctor who was a client of mine. He was a birth defect specialist or something, and he had that. And so it was crazy. Like, you went and got the surgery, and he was like, "Hey, can we work out?" And I was like, "Didn't you just have surgery like 3 days ago?" He was like, "Yeah, it's fine." I was like, "I'm not sure I want you sweating like into your surgery." And he was like, "I'm the doctor." And I was like, that's fair. So, all right. Anyway, story time's over. Thought that'd be kind of fun. Let's take a look at the shoulder here, right? So, looking at our bones that we're going to be talking about, again, you are the big ones we're going to look at are going to be your manubrium, which is your sternum. It's the top portion of your sternum here. Technically, the sternum is like the bottom portion of it, but most people consider it to be like one big bone. And so that's, you know, that's your breastbone dead center, right? And then you've got your collarbone, which is your clavicle that's going to run laterally to that, right? And then that clavicle is going to grab onto your scapula, which is right here. And so that's going to have a little bit of like movement there. This right here, by the way, this joint where your clavicle meets your scapula, this is called your AC joint, or I hate to have to say this, your acromioclavicular joint. Just really quickly, remember how I told you this was my interview? Imagine giving someone an interview where they had to say acromioclavicular joint over and over again. Rude. So that's your AC joint, and it's where the acromion process, and if we look at that, circles around the scapula and creates this little hook. That's a great picture right there. You can see there's this ridge on the back of your scapula, and it hooks around like this. That little attachment site right there is where your collarbone is going to intersect with your scapula. So there's that little hook right there. You can kind of see it coming from behind, right? And then there's the clavicle right there, and then that's the side of the manubrium there. So that's your AC joint, which is way easier to say than acromioclavicular joint. And so it's attached right there. The last bone we're going to talk about is your humerus, which, you know, you can see here's your humeral head, and there's this little like glenoid cavity right here, this little interesting little cavity where that little ball and socket joint is going to intersect so that it can have all of that range of motion. By the way, one other process that's very important in the shoulder girdle, I said we've got our acromion right here. The other one that's really important is your coracoid process, which is this little hook on the front of the scapula. It kind of honestly just looks like a little projection coming straight off of it. Not only does that create a little bit of stability in the front of the shoulder there, but this is actually also where you can see this is where half of your bicep is going to run from. And this is why your bicep actually does affect your shoulder rounding. Tight biceps can actually cause like shoulders to round forward ever so slightly. But the main thing that is attached to this coracoid process, the main muscle that we're going to spend a lot of time talking about, is your pectoralis minor, which sleeps underneath. We're looking at they're not showing there. Nope, that's also from behind. I guess I looked up acromion process. Pec Minor. It's these little tiny fibers right here that are reaching up and grabbing that humerus, right? Grabbing that coracoid process. So there's the little hook, right? So there's your acromion process right there, and there's your coracoid process, and then that is what gives you the ability to protract your shoulder, round your shoulders around the front of your body. So the shoulder girdle, right? Remember I mentioned this. So these are the bones of the shoulder in general. Your shoulder girdle, like I said, is the clavicle and the scapula. That's how that's going to be defined, right? Your shoulder joint is the humerus and the scapula. So shoulder girdle is going to have technically 3 joints, but really 2. One of those is going to be your AC joint. That's the acromion process, and clavicle, the acromioclavicular joint, AC joint. And then you will also see your SC joint. That's your sternoclavicular joint, where your sternum is working together with your clavicle. Your SC joint, like I said earlier, is the only bone-on-bone connection you've got that holds your shoulder girdle onto the rest of your body. Now, there is one other joint to talk about here, which is your scapulothoracic joint, which is a false joint. And what I mean by false joint, I mean that it doesn't have any of the typical connective tissue that we see in a joint. Like this is still, I guess, technically the interaction between two or more bones, right? Like we see like your scapula is kind of interacting with every part of your individual ribs there, and it's kind of, you know, working its way over towards the spine, right? So yeah, there's like bone to bone movement there, but there's no ligaments. There's no ligaments that hold these bones together. So we call that a false joint. And it's where a joint is held together only with like soft tissue, such as like tendons and muscles. So all the muscles, actually, that's great. All these muscles that are sort of reaching back from there, right? That are attaching that, that's all soft tissue, you know, which is a good thing because we want that to have like lots of ability to kind of protract around. We want that flexibility. So that's not really a synovial joint. Then we are also going to see your shoulder joint proper. The shoulder joint, like I said, is the humerus and the scapula there. That's where your glenoid cavity is interacting with your humeral head. And so, and this is kind of interesting because you can see actually, see this little knob right here? This little like, you know, it kind of sticks out from the humerus there. That's actually what allows like all of your rotator cuff muscles and your deltoid muscles and things like that to have a really good grip. They reach around like this. And that's also what prevents you from raising your arms up overhead if you happen to round your shoulders forward. So you guys could try this right now. Round your shoulders forward and then try to raise your arms up over your head. Literally impossible, right? Like it can't go any higher. That's because you're actually hitting this little notch right here on the top of that bone. It's like pinching right there. It's getting stuck. So we want these ligaments to be pretty relaxed for the most part until you reach like a big range of motion, you know, in which case they tighten up after that. And so we see like a lot of like mobility here, but again, like you can see stability is sort of sacrificed. That's why dislocations happen in this joint more so than others. Then we got the bones of the elbow. Your elbow is going to be your humerus at the very bottom, right? So there's your the distal part of your humerus, right? That's going to be its insertion. And then you're going to have your coracoid process. I'm sorry, coronoid process, which is this little notch right here that's actually interacting with that. And then in the back, you're going to see what's called your olecranon process. And that's this actual hook that comes all the way around. So it's like this big projection, right? Comes all the way around to the back. And so that is allowing that hinging action to occur in the elbow there, right? In the actual elbow joint proper. But there's also a little articulation that you can see here between your radius and your ulna. And so that is also doing a little bit of rotational movement. So that's where we can see pronation and supination happen. And so there will be different muscles attached to sometimes this bone and other muscles just attached to this bone. And because they are separated, they can create rotational movements. Your biceps, for instance, are in charge of that. Oh, I forgot that we got the yellow thing happening. Oh God. So that's your radio-ulnar joint. And for the record, this is where this is slightly confusing. There are actually two radio-ulnar joints. You've got the superior one and the inferior one, right? Because you've got one that's more proximal, and these bones interact with each other twice, once at the elbow and once at the wrist. And that's, like I said, a pivot type joint. And then all of your individual carpals and all your radiocarpal joints where your radius is interacting, and your ulnar carpal joints, which is ulna is interacting, right? All that is sort of working with those bones down there. All right. Any questions so far, guys, on any of the bones or hard structures?
No, all good, bro.
Good. All right. I'm gonna be doing a lot of arm waving and modeling and stuff, so I'm gonna lose this sweatshirt. Don't tell anyone I'm stripping on camera. All right, let's take a look at our upper back musculature here. So first one we're going to look at, this is having a great amount of movement on our shoulder joint, right? Is going to be your latissimus dorsi, or your lats, right? These big, they look like pizza slices, shaped muscles in the upper back area, right? I mean, really, I shouldn't even say upper back, really just your back, your whole back, it covers everything, right? Now, this muscle is massive, at least in terms of how stretched out it is. And it has a lot of connection points, and it does a lot of different things. And the more things you see a muscle do, the more likely that muscle is to be overactive. So guess what? This is a very, 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 very commonly overactive muscle. Now, does that mean that it's overdeveloped and people can do just pull-ups till the cows come home? No, remember, overactive often means weakened, right? But this is a very strong muscle that does three primary things. It is going to perform shoulder adduction, so pulling my arms down to my sides. It's going to perform shoulder extension, so it's going to pull my arms back. And it's going to perform shoulder internal rotation, so it rotates me in like this, right? So that's your, and you can literally feel that fight. If you take your hand underneath your arm like this and you squeeze down, you'll feel it. If you squeeze back, you'll feel it contract. And even if you just have your arm out like this and you rotate it around, you'll feel a contraction in your latissimus there. So that is the latissimus dorsi, right? The three things that it does: shoulder extension, shoulder adduction, shoulder internal rotation. I should mention, because I mentioned this yesterday, it does attach to your thoracolumbar fascia down here in the low back, which means that there is a little bit of like spinal extension that this does as well, which means when you're stretching your lats, you can actually get just a little bit more of a lat stretch if you do just a little bit of spinal flexion. So if you round your back ever so slightly, that can give you a little bit of a deeper lat stretch. And that's how we stretch that muscle, by the way, right? We are going to, we always stretch it by doing the exact opposite. So I'm going to take my arm up overhead like this. This could be enough to give me a little bit of a lat stretch already, right? Or I could perform like abduction. I could pull it up this way, right? And then cross it over. This is a tricep stretch here. But if I give that a little lean, now suddenly I'm abducting my arm even further away, so I can get a little bit of a lat stretch in there, which is why you see people do that on that tricep stretch. You'll see them kind of lean off to the side. But generally, our favorite lat stretch, or at least my favorite, is going to be a ball lat stretch, which looks like this. Now, you'll see what we really like about this stretch. So he's performing shoulder extension, right? So he's performing a little bit of shoulder extension, his arms extended up away. So that's going to stretch the lat already. But he's also, notice how he's got his thumbs up towards the ceiling. He's got his shoulder into external rotation because your lats do internal rotation. So he's going to pull his palm in that opposite direction. Doesn't need to flip it all the way like upside down. That's really not going to do much for you. But he's at least getting it into this neutral position, which is going to stretch that out further. Now, I will say this guy's kind of arching his low back a little bit. You can, like I said earlier, you can actually get a little bit more out of this. There we go. With just an ever so slight rounded shoulder. That can actually make that stretch just a little bit deeper. So there's all kinds of versions. There's a 2-armed version. That's actually a lat stretch as well. You can see here, looks like a Power Ranger shirt. She's taking her arm up and then like rotating away. So that's abduction instead of flexion. But both those that's a really good way to stretch out that latissimus dorsi. And this is honestly, guys, I'd say you got pretty much every client's going to be overactive in this muscle. And it's very easy to spot. You can simply look for shoulder rounding. But one of the ways I like to tell, if your client's thumbs are facing one another, like this all day rather than resting at their sides facing sort of like neutral like this, that's a pretty good indicator that there's some rounding happening in the shoulder. And so that rounding action, right? If I create internal shoulder rotation, right there it is. There's my rounded shoulders, right? So very, 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 very commonly overactive muscle, the latissimus dorsi. So then we have got your serratus anterior. Okay, so your serratus is, I call these the Manny Pacquiao muscles because this guy has a great, very defined serratus muscle. They're the little fishnet muscles right under the pecs. You know, they look like little like freaking fillets, right? Look at that. That is insane. So that is your that's your serratus anterior. So this muscle actually wraps from the back portion of your scapula around. Right? If we look at the serratus anterior, it looks kind of like this, where it wraps. That's a much better picture than the one we've got. So that wraps from the inside portion of your scapula around and then grabs these different sections of your ribs here. So what this does is this creates shoulder protraction. That's why Pacquiao is so good at it, right? Because when you're throwing a punch, you are protracting your shoulder, right? So you can see a rounding position like that. That's my serratus anterior. Now, we are talking about how our clients often have too much shoulder rounding. So your immediate assumption might be, oh, the serratus anterior is one of those, you know, super commonly overactive muscles. That would be a reasonable conclusion to jump to until you look at where this is grabbing your scapula. Look at how many of the fibers are down here on the inferior portion of that scapula. So this is in charge of shoulder rounding. It does round your shoulders around like this, yes. But here's the thing. Because it's grabbing the bottom of the scapula, you got to kind of think of your scapula. Imagine like from my fingertips to my elbow here, this is my scapula. If I grab something from up here, it would tilt this way when I pull it forward, right? But if I grab something from down here, it would tilt this way as I pull forward. So the serratus anterior actually grabs the bottom portion of your scapula. So yes, it rounds it forward around the body in general, but it gives a really strong pull from the bottom, which actually tilts your scapula back. It actually keeps it in an upright position, which is something we want to have happen. We need more of this because a lot of times when you think about like what shoulder rounding is, right? Look at like how my shoulders are sitting neutral. And then if I let my shoulders round forward, see how like I didn't just bring them straight forward. I tilted them forward, right? That's what's so common here. So the antagonist to this muscle, so this creates scapular protraction, right? So the antagonist here, like that we need to kind of like loosen up, you know, is honestly like whichever muscles are tilting forward. That's going to be things like your levator scapula, your sternocleidomastoid, right? That are grabbing that and kind of tilting that forward. We'll see those more when we get to the next stuff tomorrow. But you can see like this is a very, very commonly underactive muscle. So this concentrically accelerates scapular protraction, the rounding around the front of the body. And I know we're constantly talking about how our clients do way too much protraction, but this is one that we actually need to strengthen. The other thing here, the other muscle that does protraction that we're going to see, oh, I did it again. I did that yesterday. The other one that we're going to see that does protraction is your pectoralis minor. That Pec Minor muscle is also very commonly overactive. And so that's an example of that synergistic dominance where basically your pec is pulling your shoulders into protraction rather than your serratus helping, right? They're supposed to work together. And the problem with that is because the pec is only attached to the top, it tilts the scapula downward instead of just pulling it into protraction. We'll see that. I'll talk about that again in just a minute. So that's your serratus anterior. Then we've also got your rhomboids. And your rhomboids, there are going to be two separate fibers here. There's going to be your rhomboids major and your rhomboids minor. In this picture, you can see they're kind of just one picture, but the tiny little part right up here, right, that's your rhomboids minor, and then your rhomboids major is the big fibers here. So the job of this, right, is to accelerate scapular retraction. So this is the direct antagonist to that serratus. If your serratus pulls this way, your rhomboids pull this way. Scapular retraction, right? So pinching your shoulder blades together in the upper back. That's where we are strengthening those rhomboids. And that's definitely something we need more of, right? Again, we see way too much protraction in this world. So we need to strengthen those rhomboids. So, and then the other thing that it does a little bit of downward rotation, which that downward rotation is what I was talking about that we kind of don't want. But it only happens in those upper fibers. So it's one more reason to, when you're pinching your shoulder blades back, it's always important to tell your clients, don't just tell them to pinch their shoulder blades back, tell them to pinch them back and down. That way they can keep that scapula angled upright. Now, let's dive into three muscles that actually all kind of work together. Your trapezius muscles, your traps, right? So this is going to be, you've got your lower trapezius, middle trapezius, and upper trapezius. The lower trapezius is the lower portion. I'm just going to kind of cycle through these real quick. Medial trapezius is here in the middle. Upper trapezius is this section here. So you can kind of see these different sections right there. So they're all attached to the scapula, right? They're all attached to your scapula, and they all have fibers that run towards the spine, which means that they're going to perform scapular retraction. Every one of them, even the upper trapezius a little bit. They're all going to do a little bit of scapular retraction, but they are angled exactly the opposite of one another. If you look at the lower trapezius versus the upper trapezius, right, this is pulling downwards, this is pulling upwards. So they have two different functions, right, each of them. Your lower trapezius is going to accelerate scapular depression and scapular retraction. So it's going to pull your shoulders back, but it is also going to pull your shoulders down. Whereas when we think of our traps, right, people always think of their traps, they think about like holding dumbbells and doing like shrugs, right? Well, that's your upper trapezius. Your upper trapezius performs scapular elevation. So we often associate the lower trapezius with scapular depression, which we often need more of, because how many of your clients are walking around like this all day? Or you see people doing chest presses like this. It's like, God. We need to strengthen that lower trapezius, right? We're also going to see the middle trapezius. This one's right in the middle, so really the only thing it does is scapular retraction. It just pinches the shoulders back. This is laying over top of your rhomboids. So your rhomboids and your middle traps work together. And then the upper trapezius. This is creating scapular elevation and a little bit of scapular retraction, but honestly, like, you know, the elevation is the thing that we see the most. So oftentimes we see overactivity in these muscles here and underactivity in these muscles here. So, you know, if you've got a client with like really bad forward head posture, right? Which we're going to see again, I talk more about this tomorrow. We're going to see all these muscles again. We talk about like forward head posture, where clients kind of sitting like this, like their rounded shoulder thing, right? When that happens, we need to stretch out that trapezius muscle. So your trapezius is in charge of this. So we're going to stretch it by depressing, but you don't really feel much of a stretch when you do that. Well, luckily your trapezius has another function, which is lateral flexion. So when this trapezius muscle contracts, it pulls my head this way, and that is stretching this one. So this, because it's in the frontal plane, your left trapezius is the antagonist to your right trapezius. So how do we stretch out the left one? I tilt my head to the right, right? Or actually, I tilt my head to the left. So no, to the right. So I'm going to go here, and I'm just going to rotate that over like that. Meanwhile, that stretch probably wants to go away, so my shoulder will probably elevate. I'm like, no, no. And I create that scapular depression. And that's going to stretch out my trap muscles on both sides, which then I can maybe go activate my lower trap muscles by maybe doing some scapular retraction like this. And that's going to be a great way to turn my upper back on before I go do any upper back activity. That's going to get the right muscles firing so that they can be used during my workout properly. And that is why you guys have seen this a million times in every NASM example that we build. You know, we always see the iso prone cobra exercise, right? This is in every freaking example NASM exercise. And it's great because it's a good core exercise. It's creating spinal stabilization, but you'll notice because of the arms part and the retraction in the shoulder blades, it is a fantastic activator for your middle and lower trapezius muscles. So we love it. This is just a freaking great exercise for strengthening that low trap. This guys, I'd put him back here a little bit further down. So again, great activator, you know. So those are the trap muscles. Then we get the pecs, right? Everybody's vanity muscles here, right? Your beach muscles. Pectoralis major and pectoralis minor. So your pec major is huge. It's a big fan-shaped muscle. And I love this interesting little part right here. Notice how this muscle actually twists. The superior fibers insert inferiorly, and the inferior fibers insert superiorly. So there's a little, like, it looks like bow tie pasta, right? Like kind of inserts on the end there. So this muscle concentrically accelerates shoulder flexion. So it does do just a little bit of this, but that's really not what it's known for. And it does a lot of horizontal adduction. So when I bring my arm like this, my pec is going to contract and pull like that, right? That's going to be that contraction that brings me forward. So when you think about like what a chest press is, right? A chest press is just me swinging this shoulder joint this way. I just happen to be doing it while I'm also doing a little bit of elbow movement to keep that weight close to my center. That's also why you can lift so much more weight on a chest press than you can on a chest fly, because this is further away from my shoulder joint that I'm moving, right? So it concentrically accelerates shoulder flexion a little, but it really does a lot of horizontal adduction, and it does shoulder internal rotation. So because this wraps around my humerus and grabs the outside, when it pulls it this way, creating that internal rotation. So in a way, your pecs and your lats work together. They are synergists to create that internal rotation of the humerus, right? Something that we have a little bit too much of. So again, very commonly tight, overactive muscle here. Definitely something we need to kind of loosen up in order to get our clients to stop rounding their shoulders forward. The other one we're going to see is the Pec Minor, which is the real, honestly, like when it comes to the pecs, the real big bad guy here. So that's your pectoralis major, accelerates shoulder flexion, horizontal adduction, and internal rotation. Your Pec Minor, though, notice how like this attaches to your humerus, right? This attaches to your scapula. So that is going to concentrically protract the scapula. So this is supposed to work together with your serratus anterior here. But instead, it kind of takes over and does all the work instead. Now, because it's attached to the top, you know, like I said earlier, it's the equivalent of pulling from the top rather than just pulling the whole thing, right? And that just tips it. That, I mean, it does create a little bit of protraction, but it tips it forward, right? And that's where we see that tipping rounded shoulder, right? That tight muscle in the Pec Minor. Now this is underneath your pectoralis major, but you can find that insertion part right here. right underneath, if you kind of dig into your scapula, you'll find that little like coracoid process. And it's going to be tender, let me tell you. And you can kind of press on that, and that'll kind of hopefully get that to relax. Good Lord. That is where these come in really handy. A lacrosse ball pressed into the wall is a great way to kind of get into that pec minor and try to get that to relax. Oh, and the other thing is also when you're doing like a pectoral wall stretch, like, you know, again, this is in charge of horizontal adductions. How do we stretch it? We do horizontal abduction, right? If you want to get further into the pec minor, rather than going 90 degrees the way I'm at right now, just bring the arms ever so slightly higher. Just a little bit of that is going to, you know, tilt that scapula backwards. And so we'll see, here's a great pec minor stretch. I mean, that's not bad. This is really much more of a pec major stretch. We need a little bit of like, we need them to raise their arm up a little bit. Just a little bit. Good Lord, internet, come on. Where's Brent Bookbush when you need him? Definitely not this version. That's straight up dropping down. There we go. So bent elbow, straight arm, either version, you're gonna pull straight back. Also, I love like a good broomstick stretch. That's one of my all-time favorites. Just up and over, you know, great way to kind of loosen up those pec muscles. All right, next one. Let's move into the delts, right? Let's talk about getting those shoulders. So deltoid muscles, you have got, these are kind of fun, man. The deltoids are unique. There's 3 heads to them, and they're all kind of wrapping around the shoulder here. And so actually, if we look at, let's see here, deltoid muscles. Okay, good. I was wondering what kind of image I was going to get here. So you can see like the individual fibers here, right? You've got your front deltoid, that's your anterior deltoid. Your middle deltoid, that's your medial deltoid. This is also sometimes called the lateral deltoid. So that's freaking nice, right? Like medial, literal opposites of each other, right? It's not called the lateral deltoid. It's the lateral head, even though it's your medial deltoid. So annoying. But that's called the medial deltoid. That's its real name. And then the posterior deltoid, which is the rear fibers, right? So you've got the front, middle, and back. Your first one we're going to look at is the anterior deltoid. That's on the front portion of the body. So the anterior deltoid, you can see, is going to run and concentrically accelerate shoulder flexion and a little bit of shoulder internal rotation. So it is tying on the front, so that's going to create rotary movement this way, right? But really its big thing is shoulder flexion, right? Its main job is to raise your arms up overhead like this. It works with your pectoralis muscles to create that scapular, that shoulder flexion, right? So when you're trying to strengthen the front of your deltoids, doing like front deltoid raises like this, or, you know, plate raises, things like that are really, really good. Then you get your medial deltoid, and this is sort of the meaty part of your shoulder. Like when you're looking at someone's deltoids, like you're looking at their shoulders and you see like the big muscular part, that's the medial deltoids, the kind of making up most of the head there. And this is going to accelerate shoulder abduction, right? So we can see one deltoid was in charge of raising like this, and now one deltoid is in charge of raising like this, right? So shoulder abduction. So when you look at like a shoulder press, right, that's going straight up. That's shoulder abduction. I'm taking this bone and I'm abducting it away, right? Lateral raises, military presses or shoulder presses, right? All those are really good for the medial deltoid. Then we've got your posterior delt, which is these back fibers here. This is going to do shoulder extension. So all these deltoid muscles kind of work, you know, in different directions. You've got one going here, one going here, and one going back here like this. It also does external rotation, which is why this muscle is often very underactive because this little tiny deltoid muscle has to work against your giant lat muscle. You know, the lat, as it's running up and grabbing the front out, internally rotating, right? This muscle has to work to externally rotate. Luckily, it's got your rotator cuff muscles, so it's got some assistance there. But for the most part, that posterior deltoid, it's in charge of that external rotation, throwing your shoulder back, which is one of the reasons why we do reverse flies, right? That's not bad. Like we like reverse flies because that's a good way to kind of get the rhomboids in the middle trapezius going. But remember, this is shoulder horizontal abduction, right? A lot of people think this is a good posterior delt exercise, but it's not really directly what the posterior delt does. Your posterior delt does external rotation and extension. So if you actually want to get your posterior delt, a lot of times, one of the best things you can do is just a cable external rotation, just like this. That little bit of external rotation can be a great way to kind of carve that muscle out. Not to mention, you're getting the benefits of working. You gain the benefits of working on your rotator cuff muscles as well. So those are our different sections, right? Anterior deltoid accelerates shoulder flexion and internal rotation. Posterior deltoid accelerates shoulder extension and external rotation. So these two are absolutely antagonists of one another. And then the medial deltoid is kind of stuck there in the middle, like, guys, can we get along? It's doing shoulder abduction. It's going to go to the side there. Now, one muscle that's not 100% part of your deltoid group, but it is tied very closely, is your Teres Major. This guy right here, another one of our bad guys, often overactive, right? One of our tight muscles. So the Teres Major is going to accelerate shoulder internal rotation. We talked about the lat doing internal rotation, right? Well, Teres Major is also going to do that. And you can see it starts on the back portion of the scapula, runs around, and then it's hard to tell in this picture here, but it's going to grab your humerus in such a way that rotates it forward, right? It tips it towards your midline. Too much, right? We don't need enough of that, right? It does do a little bit of adduction as well, just for the record. But again, like that's your lat's job. You know, your lat is huge. It's got all the adduction it needs. So this Teres Major muscle is often very, very, very overactive because we see way too much shoulder rounding in this world, right? So then we got to look into your rotator cuff. So we get your rotator cuff kind of grouped up here. Your rotator cuff is a group of muscles, right? So first one we're going to see is the Teres Minor. The Teres Minor is going to accelerate external rotation. So you can see these muscles are arranged opposite. Look at the Teres Major. Where am I? Look at the Teres Major here, right? It runs under, actually, you know what? I'll pull up a better. Teres Major. There's sort of a better picture, right? There's this Ken Hub picture, yeah, that I'm thinking of. This one's great, right? Like you can see, it comes down here and then it grabs the front of the humerus. That's why when it pulls, it creates internal rotation. But then you've also got your Teres Minor, which does exactly the opposite. It's going to run from the same spot, or at least close to it, right? It'll just a little bit more laterally, right? And then it grabs onto the back of the humerus right there. So these muscles are attached kind of like this. You've got one in the front and you've got one in the back, and they pull to create rotary movements like that. But Teres Major's got help from the freaking lats. So guess who wins that battle? The poor Teres Minor can't keep up and keep those shoulders rounded back, even though it's got some help too. So that's your Teres Minor. It's going to externally rotate. Then you've got your infraspinatus muscle. So think about the names here. Infra standing for inferior. Spinatus means like spine. We're not talking about your spine. We're actually talking about the spine of your scapula, this little ridge right here. So it's inferior to the spine of the scapula. That's why it's your infraspinatus muscle. And it is also in charge of shoulder external rotation. So you can see the Teres Minor, which actually you can't see. The Teres Minor and the Infraspinatus are both going to work together to be your external rotators. Then you're also going to have your scapular subscapularis. This is part of your rotator cuff, and this is often a muscle that this does shoulder internal rotation, which we've been talking about. You know, we do way too much of. We do way too much of it, and so we can't really. We don't want to do any more shoulder internal rotation, but this is actually a muscle that could possibly need strengthening because the subscapularis is supposed to be doing the internal rotation and it can't. It's where the Teres Minor and the lat is kind of taking over. So occasionally when you do have like rotator cuff problems, you do actually, you know, you want to do external cable rotations, but sometimes you'll also want to do internal rotations. So working in both directions actually can be very helpful, depending on like if there's just overall rotator cuff dysfunction. So that's the subscapularis. Then we've got the supraspinatus, where we had our infraspinatus, which was underneath the spine of the scapula. Your supraspinatus, it's another one that's hard to see. This muscle, can I get that blown up, please? This muscle lives on the top above the spine of the scapula. It's superior to the spine of the scapula, and it grabs onto the top of your deltoid, grabs onto the top of your humerus right here. So again, this is in charge of shoulder abduction. So this is supposed to work together with your deltoid, right? Your medial deltoid, but often becomes very underactive. So those are your rotator cuffs, right? Those are the muscles that create all the stability inside the arm there. Any questions? Oh God, we lost. How did we lose? We lost Kenny. Any questions, guys? Questions, comments? All right.
All good.
Let's move into the elbow. All right, let's talk about the guns, right? So strengthening the arms, right? If you're trying to carve those arms out, we got a couple different fibers here. Lot more bicep muscles than you might be aware of. You'd think that the word bicep, which means two, right, would end at two muscles, but it's actually a larger group than that. So first we're going to see the biceps brachii. This is going to accelerate elbow flexion. Shocker of the year, right? There's your curls, right? That's what your biceps in charge of. Now, it does do that elbow flexion, but the other thing that it does is supination. So it actually also contracts when you pull your arm back like this. So when you supinate, your palm face up, you can even see, right? See how my bicep is actually contracting? It's in charge of that supination movement. And then it does do a little bit of shoulder flexion, actually. Sometimes you'll even see, like, clients will get a little sore. They'll say, like, they'll do, you know, if they do lateral raises all the way overhead, or frontal raises, they'll feel in the biceps sometimes. We don't want them to feel it in the biceps. It's just, if they're overactive, they like to fire, and it's like, stop. But that is going to be your biceps brachii. Its main job is definitely elbow flexion, but it does do supination as well. That's why you see that bodybuilder pose. Builder pose, supination. I don't know if I'm going to see a picture of it, actually. Yeah, kinda. Where's the one I'm thinking of with they always do the finger thing. Yeah, I mean, these are all fine. They're doing like lots of elbow flexion. Come on, bodybuilder. Is it, sometimes it's like, wrist twist. Let's see if the internet needs a more simple explanation. Huh. I'm not finding the post. I have no idea what I've no idea what friggin' poses are called. Let's try one more. Let's try external rotation. Oh, bodybuilder pose. No. All right. Anyway, you'll see sometimes they'll do this thing where they hold their palms back like that. And that activates that bicep a little bit more. So that's your biceps brachii. It's kind of the main bicep muscle we think of. By the way, you'll notice it's tied to two different sections. That's what allows it to have that pronation supination effect. You can see some of it starts here on the humerus and some of it's here on the coracoid process. And then it grabs down here, creating that rotary movement. Now, the exact opposite of that is your triceps brachii, okay? This does shoulder extension, right? So this one contracts going this way. And so elbow extension, and it also does a little bit of shoulder extension. Look at how it is tied to your scapula here, right? So it can pull, it's got a little bit of an anchor so they can pull backwards like this, which is why sometimes you'll feel it in your triceps when you're doing, presses back like this. And that's another great way to kind of activate those triceps. When you're doing like a bent over tricep, like let's say you're doing like tricep kickbacks, right? You don't just want to line them up into your body and then just kick straight back. You actually can pull them a little bit further, and that will give them an even deeper contraction because now you're doing both. Or you could do my favorite, which is a combination of the two, where you move into it, kick back, and then come down. And kick back and come down. That's one of my favorite versions. So that's your triceps brachii. Now, this is another example of where like NASM's they're doing a good job, but like I got a slight little hitch with this. There are two different heads to your triceps. You've got a long head and a short head. And so you can work the long head oftentimes when your arms are a little bit more in shoulder flexion, because what that does is that stretches out the short head and deactivates it so where you can only use the long head. So oftentimes movements that are like skull crushers are oftentimes the long head because you've got your arm a little bit tilted away, versus like a tricep press down where you're doing something like this. That's very much going to be the short head closer to the elbow. So if you've got if you're trying to build up your triceps and you find that this side is, not building up as much as like up here, you need to change up the type of tricep exercises you do. Take your arms up here, that will build the upper portion of the arm. Take your arms down, that will build the lower portions of your arm. Then we've got another biceps muscle here, which it's kind of a biceps. It's really more of a forearm muscle, but this is your brachioradialis. And it is going to run from your bicep. Oh my God. Run from your humerus down all the way into your wrist here. So this is going to accelerate elbow flexion as well. So this is working with your biceps muscle, right? But this one is the one that's located just down here at the very bottom. So if you're trying to fill out like that bottom portion right there, this is where you actually need to do a little bit of a slightly different biceps exercise, right? Like your traditional bicep, you can really get really well at, but you need to also do a little bit of this elbow movement there. So keeping your forearms in a more neutral position, like hammer curls, is a great way to put a little bit more pressure on that brachioradialis. And then we've got the brachialis muscle, which is another bicep one, right? And this one is located, this is honestly the biceps femoris of your biceps. It starts in the middle, so it cannot do shoulder flexion the same way that our biceps brachii did. And these are the lower fibers down here. So that's also going to do elbow flexion. Now, this doesn't do supination. So this is another one that you can strengthen. But actually, one of the best ways to do this is to fully stretch your arm out before doing them. If you ever see somebody doing drag curls, where they've got like the barbell like this and they drag it along the body, that's a really great way to strengthen your brachialis instead of just your normal biceps brachii, which we would get here. So again, angles are really kind of important when you're trying to carve out the different portions of your arms, right? If you're really trying to have like a fuller arm or a more carved out arm, you've got to have like variations of these arm exercises. Neck muscle, that's a picture of the calf. All right. Any questions so far, guys? Oh man, we lost Kenny. We haven't gotten him back yet. All right. We do have a couple neck muscles that I just want to talk about here really briefly because they do affect your scapula. They create a little bit of scapular movement. So I want to spend more time on these tomorrow, but I want to mention them now. Yeah, they're not in your notes, but I'm going to mention them. So one thing that does affect scapular movement is your levator scapula, which elevates your scapula, right? So your levator scapulae or levator scapula is in charge of accelerating cervical extension. So it does do a little bit of this, right? It does kind of pull your head backwards. It does a little bit of rotation, right? So it is in charge of that. But the big thing that it does it elevates your scapula. So it creates scapular elevation. And because of where it's attached, you can see this is running like right here along this ridge. Again, remember the angle, right? My scapula is not just going to go straight up. It's going to go up and forward. So it does create a little bit of that downward rotation of the scapula. It's like you're digging your, grabbing the back of your scapula, like digging its head down, right? Not awesome. Something we definitely see way too much of. So when you see a client with a rounded shoulder forward head situation, here's one of our most commonly overactive muscles. And like I said, we'll talk more about that tomorrow for sure. And then we've got my favorite muscle, because it sounds like a dinosaur, your sternocleidomastoid. It's named after being attached to your sternum and your clavicle and this little masseter right here in your jaw. So that's your sternocleidomastoid. And that muscle accelerates a little bit of cervical flexion, which is this movement. Again, we see way too much of that in this world. A little bit of rotation and a little bit of lateral flexion. So this is another very commonly overactive muscle. And because it's attached to your collarbone, we want to mention it today because this muscle, when it gets really tight, can further create that tipping motion. And we see that rounded shoulder situation. So we not only need to pull the shoulders back, we also need to pull them, back in terms of, we need to get them into a more upwardly rotated instead of downwardly rotated, right? And then in addition to that, we eventually need to pull the head back. And there we go. There's our sort of ideal posture. All right, any questions on the muscles before we move into the movements and agonists?
No.
Cool. So agonists, right? Well, that's not true. Sorry, movements. So we've got shoulder protraction and retraction. Protraction is technically abduction because it's moving away from the midline. Retraction is moving towards the midline, so technically that's adduction. But they get their own special names. It's protraction and retraction. You'll very rarely see these two terms. So protraction, rounding the shoulders forward. Retraction, bringing them backwards. You guys want to see a freaky video? Here's a guy with no collarbones. With no collarbone. This guy can do way too much shoulder protraction. I pulled this up in class already once, but whew, that is wild. No collarbone. So a little bit too much protraction there, I would say. Then we've got scapular downward rotation and scapular upward rotation. Downward rotation, right, is going to be tilting down. Upward rotation is tilting upwards, right? So again, we're seeing like that levator scapula, right? It's going to create too much of that downward rotation that we're not looking for. We're going to see scapular elevation and we're going to see scapular depression, right? Going up and going down. And those are sort of our key movements of the shoulder girdle. Do we have the shoulder joint movements coming up soon? There we go. Okay. This PowerPoint goes in a slightly different order. So then we've got what muscles are primarily responsible for our scapular movements. If we're looking at scapular protraction, the muscle, the rounding forward, right? That is going to be your pectoralis minor, right? Those little fibers that are attached from the ribs up onto that coracoid process, and all of those little serratus anterior muscles, right? Those little tiny fibers that reach out and grab each of your ribs individually. So push-ups, bench presses are really, really great. Now, generally, we need to loosen up the pec minor and strengthen the serratus anterior. This synergist muscle is inhibiting this agonist muscle. This is supposed to be the main muscle we use, but we tend to use this one, which is, again, what tilts the scapula. So one of my favorite exercises for this is what's called the push-up plus, which is one of my favorite scapular protraction movements, where you actually, no, that's regular push-up. All right, we'll just do a video. It looks like this. So he's going to go down into a push-up. Oh, no, he's not. He's okay. So he's only doing the plus part. I like to do these with an actual push-up, but you can see he's just going to retract and then he protracts, and that's the contraction of that serratus anterior. So if you're trying to get those little Manny Pacquiao muscles, that is the movement right there. Or, punching. Punching is a really good one. Then we've got scapular retraction, which is going to be your middle trapezius and your rhomboids muscles, right? So your rhomboids right here and that middle trapezius fiber. Those are going to pull and pinch those shoulder blades back. We've got scapular upward rotation and downward rotation. Upper rotation is going to be your middle traps, lower traps, and serratus anterior. So again, upward rotation, getting us back to that neutral position with our shoulders tilting the way they're supposed to, right? Tilting and staying upright. That is going to be the middle traps a little bit, but the big one here, lower traps. The lower trap is going to tilt you back upright. So that's definitely one we want to strengthen. And then we see that serratus anterior muscle, right? Which is kind of surprising because it's in charge of protraction. But again, it's protraction, but it's pulling from the bottom. And that's why that tilts that back up, right? That's your scapular upward rotation. The thing we see way too much of, scapular downward rotation, where the pec minor is dumping that scapula forward. As well as like the upper portions of your rhomboids, but don't think of the rhomboids for thinking of that. Think of that downward rotation. Then we got scapular elevation, levator scapula. No shocker there, no surprise there, right? It's elevating the scapula. And then we see the upper trapezius as well, right? Those trapezius fibers up top. And then again, like the rhomboid minor, right? Like those little tiny fibers at the top of the rhomboid, a little bit of that, but don't, again, the two I want you thinking of, levator scapula and upper trapezius. And then scapular depression. Oh God, it's doing the yellow text thing. It does. I hate this. Yeah. So that is going to be, pressing downwards. So your lower traps are going to do that, as well as a little bit of your pec minor, but the pec minor really is not supposed to do most of that. That's just really the job of your, lower traps. This is one of my favorite low trap exercises, by the way, is this right here. This is a great way to kind of get better at that. If you've got a client with elevated shoulders, scapular pull ups. So this is a very small movement, but it's a very good one. That's not what I'm looking for, buddy. There we go. So that right there, that little tiny, he didn't do a pull-up. He went from an elevated position to a depressed position. So he's using his lower traps to contract and pull him up like that, right? So upper traps are now kind of in a shortened position, but then he strengthens and shortens his lower traps, and that pulls him upwards. So really great exercise there. All right, let's look at the shoulder joint. So that's the shoulder girdle movements. Then we've got our shoulder joint movements. We've got shoulder abduction versus shoulder adduction, right? And then we've got our shoulder flexion versus shoulder extension. And then we've got shoulder horizontal adduction versus horizontal abduction. So horizontal adduction, horizontal abduction. And then lastly, we've got internal rotation versus external rotation. So the muscles that are responsible for shoulder flexion are going to be your anterior delt. That's going to contract to pull your arm upwards, right? And we're going to see the upper parts of your pec major. So the upper portions of your pecs are going to do a little bit of movement when you do those front raises. Shoulder extension, the exact opposite. That's going to be your teres major, which is, that's the time that we actually do want to strengthen that muscle. But the latissimus dorsi, honestly, is the big one here, right? Your lats are responsible for pressing down like this. This is why the lat press, where you take your arms, up overhead and like this, right? Dumbbell lat press, or if you're doing like the cable lat press, right? Just like this, that's that shoulder extension getting into that lat muscle there. And then the lower portions of your pec actually do this, your pectoralis major. Remember, we talked about the upper fibers versus the lower fibers are kind of antagonistic of one another because it creates this sort of twisting action before it inserts. So the lower fibers, but honestly, think shoulder extension, think latissimus dorsi. Abduction, that's going to be your medial deltoid, so the sideways part of your delt, right? Your supraspinatus living there on top of the scapula, and a little bit of the pec major, right? The pec can help with this just a little bit, but honestly, the big one here for shoulder abduction, guys, think of the medial deltoid. That should be the first muscle that pops into your head. In terms of shoulder adduction, think of your lats. So again, now we see like the lats are prime movers for both extension and adduction of the shoulder. So pulling the shoulders down this way, right, or pulling them backwards, both of those are definitely latissimus dorsi movements. Teres major assists in that just a little bit, but nothing to write home about. And then the pec major a little bit, yeah, pec major there. Then we got our rotation, right? Internal rotation. That's going to be your teres major, which is, that little, not a rotator cuff muscle, but it lives near your rotator cuff. Subscapularis. And then the big one here is that latissimus dorsi, right? That overactive lat muscle that's pulling our shoulders, bringing the thumbs facing each other. Then we see the external rotation. That's going to be your rotator cuff, particularly the infraspinatus and the teres minor in the rotator cuff. That's going to do the external rotation. And then the posterior deltoid, right? That does a little bit of that as well. So external rotation there. Then we've got horizontal abduction, which is the reverse fly. That's going to be your posterior deltoid for sure. A little bit of the medial deltoid, a little bit of the infraspinatus, and a little bit of the teres minor. But really the big one here is that posterior delt. So again, reverse flies are a great way to get that exercise going. Then we got horizontal adduction, which is the classic chest fly. That's your pec major, right? That's the big one we want to think of there. A little bit of the anterior deltoid. I mean, obviously, when you guys are doing chest exercise, you can probably feel a little bit in your anterior deltoid as well. Chest and shoulder kind of feel like they're working together there. And then there's another one called your Coracoid, which we didn't really talk about. But in the same way that you had your Brachialis, which is running from like the middle and then onto the forearm, this is running from the middle up to the coracoid process. So it does a little bit of that as well, but oftentimes this is another overactive muscle that we see. And then we get the elbow, right? Looking at the elbow, we got elbow flexion, we got elbow extension. Elbow flexion, sagittal movement, decreasing that angle. Elbow extension, sagittal movement, increasing that angle. We'll also see pronation versus supination, right? Give me soup. So when we look at that, bicep curls, right? That's a elbow extension movement. So your biceps brachii, both fibers of that are going to work. Your brachialis, that little short one right here, and your brachioradialis, which is this big long one right here. All of those are your bicep muscles. So change up your angles there, right? Do a classic I like a good supinated, regular old bicep curl here. Or I really like I'll lean back. This is hard to demo, but imagine I'm on an incline bench, okay? There we go. Now I'm inclining, right? And then I let my arms down like this, and I do curls like that. I'm moving my bed. That's going to be a great way. That's going to be a great way to activate that biceps brachii. If I want to get my brachialis, I can do a little bit more of like a drag curl, right? And if I want to get like my brachioradialis, I can do hammer curls. So all three of those are different heads of the biceps. Or reverse curls, by the way. That's a really good one too. Reverse curls, which are freaking brutal, but awesome exercise. Elbow extension, right? Pulling this way, right? Shortening that muscle. There is another little muscle in there that we didn't mention. Your anconeus. It's this little itty bitty stabilizer that lives like right underneath here. But again, your triceps, you can see there's two separate heads here. There's a long and a short head, right? Like I said, in your triceps, you do want to make sure that you've got different angles there as well. So straight down or ever so slightly elevated, right? Those are going to be different heads of the triceps. And then we've got our pronation and supination. Pronation is primarily going to be that brachioradialis muscle, that big long one, right, that runs down. That is somewhat a bicep muscle, but somewhat a forearm muscle. And then supination is that biceps brachii. And then I love this, the brachioradialis again. How weird is that, right? This is the only time we see this muscle. Well, I mean, it's not the only time, but in the arm, it's this muscle's in both lists. It's antagonistic to itself because it has different fibers. So it's kind of a fun one, actually. But that is, and then there is a muscle actually called your straight up pronator teres and pronator quadriceps. Those are your pronator muscles. And then the rest of it is wrist movements. Wrist flexion, wrist extension, adduction and abduction. But honestly, they're just gonna kind of have this list at the end. Yeah, I think that's maybe why it's in yellow. It's like sent to us and they're like, you can include this if you want, but you don't have to. Anyway, there's all these little muscles in your wrist that you can strengthen and stuff that do different things. And there's millions of them. None of them are in your textbook, so you're not going to get tested. Look at how many more slides there are left. You're not going to get tested on those. I should just delete those slides, but I'm always chicken to modify NASM stuff. That's it, guys. That's all I got for you today. Oh God, we lost another one. Any questions?